Well, we are going to get started. Good evening. My name is Katie Barkley, and I'm here representing CLC Network, and this is the ADHD and Your Child webinar with Robert Bulten, Dr. Robert Bulten, and Doug Bouman. Just a few housekeeping items before we get started. If you have any questions throughout the webinar, please type them into the chat feature or the My Q&A feature, and I will be moderating that throughout, and we'll pass those questions along to our presenters today. And then also, we're going to be referencing a couple documents. So if you haven't already done so, please go to clcnetwork.org/ADHD2015, and you can download those documents and print them out if you're able. So you'll want to have those in front of you when we're talking about them. Our presenters today, we have Doug Bouman, who's a school psychologist. He is the Director of Evaluation Services here at CLC Network. We're also known as the Christian Learning Center here in Grand Rapids, Michigan. Doug is a nationally certified school psychologist and is a licensed master's social worker. He's a graduate of Calvin College and Central Michigan University here in Grand Rapids, or in Michigan. So welcome, Doug.
Thank you.
We also have Robert Bulten, MD, and he previously practiced general pediatrics for 12 years and has been practicing behavioral medicine, including ADHD, autism spectrum disorder, and mood disorders for the past 30 years. He is a graduate of Wheaton College and the University of Michigan Medical School. So welcome, Dr. Bulten.
Thank you.
And I'm going to pass the mic over to Doug to get us started.
Actually, we'll let Dr. B.
Okay. First thing we want to talk about with ADHD, and I interpose ADHD and ADD. It's just easier to say ADD. We want to talk about what ADD is not. First of all, it's not laziness. So many kids grow up under the impression that they are just lazy. They're not trying hard enough if they'd only put forth more effort. And if we could actually put an effort meter on them, we'd find out that they are working harder to accomplish less than most kids. ADD also is not from bad parenting, and it's not from bad teaching. It never hurts to be the very best parent that you can be or the best teacher that you can be, but that's not the cause. It's highly genetic. It's actually the second most heritable condition in the human genome, the first being height, of all things. The next part is just looking at fit. I personally don't like that this is called a disorder because it really is just a poor fit between the way a person's brain is wired and the expectations of society. 200 years ago, this was not a problem. They could have a niche in life, working on the farm with Pa, if they made it through 5th or 6th grade. Nowadays, you need a master's degree in agribusiness to be a farmer. So it's just that bad fit that kids aren't meeting the expectations of modern-day society, and that takes place primarily in the schools. Okay, Doug.
We're going to talk a little bit about some of the primary symptoms of ADHD. If you have downloaded document 1, it may help us just to tease out some of the symptoms related to inattention and distractibility. This document 1, it's called 3 Attention Controls. There's just one document that I'd have available when you're trying to sort through this. This may be the one in terms of picking up some of the subtleties and complexities of ADD. Fact is some of the quietest forms of ADD are almost worse. If you have a 6-year-old who is driving everybody crazy and and the like, it's not that hard to make a diagnosis. But the kids who are more quiet or subtle, those kids can go under the radar and be missed or misinterpreted. And so one of the real goals here at CLC Network is to make sure that kids are not misinterpreted or this disorder missed, because it can have pretty significant consequences. So if we reference this document 1, I hope you all have it. If you don't, you can download it later. Just think about in it the sections A and B under mental energy controls and processing controls is a significant list of symptoms that are often seen with kids with the quieter form of ADD. So sections A and B are about the inattentive. One area that is often missed is the whole notion of inattention related to a fast-draining battery pack. This is only seen, however, when the task is important but not interesting to the student. For them, mental effort is so effortful, they have to wrestle themselves to get going. They have trouble keeping going. And after all that effort, the product that they produce is frequently less than some age or class peers, with the result that they have more homework to do when they head for home and less fuel or mental energy to do it. Distractibility, in some respects, ADD or the attention piece of this is more about having the right fit of attention for the situation they're in. Sometimes situations require a wide-angle lens. Other times it requires a zoom-in lens. It often seems that the more zoomed in the task requirements, the more quickly their battery pack runs down. So for them, effort is quite effort. Another real important thing to keep in mind is low boredom threshold. These kids often find it very difficult to start, stay with, and complete tasks that are well within their ability. They know what to do, but are unable to produce what they know. If we shift down to the bottom section, I want to just talk a few minutes about impulsivity, hyperactivity. Sometimes these are called executive functions, kind of the orchestra conductor of the brain. And actually, it isn't a bad analogy if you think of these production controls as being the orchestra conductor who at times is not conducting. And the result is impulsive thoughts or words. We sometimes call it the ready, fire, aim approach, or fire, 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 what is ready and aim. And it is very taxing on the caregivers, be it the parents or the school staff, and particularly for the student himself or herself, who may deeply desire to do well, but despite their best efforts, are experiencing pretty significant difficulties with impulse control and motor restlessness. I guess here at CLC Network, a lot of the students that we do evaluations of are more the subtle form of this. The mental energy processing controls, or ADD, quiet type, inattentive type, really can take a toll on a student's psychological well-being as well as their ability to do school, even in the midst of very excellent behavior. They may not be impulsive at all. Another puzzling attribute of this whole arena is that it's not there all the time, it's just there too much of the time. When does ADD go away? When the task is new, novel, exciting, preferred, pizzazzy, and engages their emotional attention. And that can lead people to think that a student doesn't have breakdowns in attention. The real test of attention is when the task is important but not preferred or of high interest. How well, as compared to age peers, is that student able to start, stay with, and complete tasks? And it's real important for parents and educators alike to have a grip on this. So I would just ask you to reference this document 1 as kind of a document that you can go back to if you're wondering about a student. So one of the other symptoms that has just more recently, in the last probably 10 years or so, come onto the scene is emotional reactivity, and Dr. Bouman's going to chat about that. Should be on your slide.
I oftentimes think of ADD as really a problem with control, self-control. They have trouble controlling their thinking. It isn't that they're not paying attention to anything, it's that they're paying attention to everything. They can't control their thinking. They can't control their bodies, and we call that the hyperactivity, and they can't control their impulses. But they also can't control their emotions. They are highly reactive. Now, not every kid, again, each of these four qualities, inattention, impulsivity, hyperactivity, and emotional reactivity, are on a spectrum. And you don't need all four qualities to the max. You can have one or two or sometimes all of them. Sometimes this emotional reactivity gets confused with bipolar disorder, and those are very hard to tease apart, but it is possible to do that with a skilled clinician. But just keep in mind that these kids can fly off the handle, especially when they're frustrated, and it doesn't take a whole lot to frustrate them.
Would you say they're thin-skinned?
Oh, yeah. And especially to the word no.
Yes.
Okay, let's go on to the next slide. One of the things that makes ADD so complex is that it rarely occurs in a pure form. The majority of kids with ADD have about 75% of them have something else going on. And the most common of those is what's called oppositional defiant disorder. And if you think about those words, you can see that has it's self-explanatory. If you say that the carpet is pretty, it's beige, they will complain that no, it's not pretty, it's brown. And if they're highly oppositional, I oftentimes say they'll make great lawyers. They've got one foot in law school already because they love to argue. And they're kind of just defiant and in your face. About 40% of ADD kids are also oppositional. The good news is, the bad news is that it's very hard to live with a highly oppositional kid. Very draining, takes a toll on marriages, takes a toll on parenting because it takes industrial strength parent to deal with a kid like this. The good news is that if the ADD is well treated, the incidence of oppositionality drops from 40% down to 15%. And so that's hopeful. Now, if for that 15% where the oppositional defiance remains, then you have to look for mood disorders. And about a third of kids with ADD have some sort of a mood disorder. Of those, anxiety is the most common. There's also depression, OCD, and there's some truly bipolar kids that are also ADD. And it's important to tease those out. Sometimes professionals will say, well, you've got to first look at the mood disorder because if they're anxious, then that's causing the ADD symptoms. My experience is usually the other way around, that if they are having ADD symptoms and anxiety symptoms, worries and fears, that one reason why they're anxious is because of the ADD, and not infrequently when the ADD is treated, the anxiety gets better. So the ADD is more likely to cause the mood disorder than the other way around. And one way I look at that is ADD people don't experience time like other people. They experience all of time in the now. And when you experience all of time in the now, that means that everything that's on your plate to do, for a kid, it may be schoolwork, it may be going to Boy Scouts or chores or whatever, everything that may be on their agenda of what they have to do, they subconsciously perceive that that's only going to be done, the only time they have to do that is in the now. And they can very quickly be overwhelmed by what they perceive to be too much to do and not enough time to do it in. Again, going back to this effort that Doug was talking about, they work and they work and they work. They put forth so much effort trying to just get their poor brains organized so that they can manage what they have to do, but the results aren't very good. And when you work and work and work and you don't get very good results, it's very easy to get eminently discouraged, and that's oftentimes kind of misdiagnosed as depression.
One of the interesting indicators of this, or an attempt of the student who's really wrestling with attention and focus, is their adaptive use of procrastination. So we used to think procrastination was just automatically a poor habit or a lack of self-discipline or irresponsibility. But in a unique sort of way, procrastination becomes a strategy by which the student, or adult for that matter, invites anxiety into their mind to change their own brain chemistry so that the only way they can get going on something that's important but eminently boring is to wait. And any efforts by teachers or parents to encourage them to start early really meets with quite a bit of failure. And it's a different twist on procrastination from that perspective. You want to talk a little bit about substance use?
Yeah. One of the co-occurring conditions is substance use or abuse disorder. And it's always interesting to talk with, 80% of my practice are adults, so I get to talk with them about their life's experience with ADD. And many of them have turned to alcohol, marijuana, cocaine, heroin, to quiet their restless brains. Their brains are flying all over the place, and they will do anything to try to quiet that down. So, again, does ADD cause substance abuse, or do substance abusers, are they trying to self-medicate? That's always a very good question. There was an interesting study done at Harvard back in the 90s, and you'll see that in the box down at the bottom of this slide. They took a group of kids, these were teenagers, average age of 15, and they divided them into three groups. On the left are those that are untreated ADD patients, and that's medically untreated, and they had a 34% incidence of illicit substance abuse. That was primarily marijuana. Then they had a control group. Those are people that did not have ADD, and they had about a 10% incidence of substance abuse. And then they had a treated group, those that were treated, and even back in the 90s, optimal treatment was not available because optimal medical treatment was not available just because the right drugs and the right delivery systems had not yet been developed. But in the treated group, only 13% were using illicit drugs. And there's no statistical difference between the 13% and the 10%, but there's a huge statistical difference between the 34% and the 10%. So the conclusion that the Harvard guys came up with was that that treating the ADD appropriately is actually helping prevent later substance abuse. Okay, Doug.
We're going to talk for a few minutes about the impact of ADHD or ADD on school functioning. We here at CLC work with many different schools across the Midwest, and so we think it's really important to keep a handle on how does this issue of ADD impact school functioning. If you turn to document number 2, and if you don't have it, we'll just kind of go through it as best we can. You can download it later. It just says ADHD, 4 areas of potential impact: school functioning being skills, behavior, which we've already talked about, and emotion, and relationships. One of the things that we're finding is that if students are failing to make progress in, for example, if you look in the left column, in reading skills, in other words, they've been given excellent interventions by parents and teachers and specialists, and simply stated, the return on the efforts put forth by these professionals, by the parents and the student, are quite meager. It raises a suspicion, or at least the possibility, that behind the scenes breakdowns in the attentional system could be the culprit. So we listed some of the things that you would see in reading skills. The difficulty applying skills that they learn, omitting or inserting words while reading, jumping over a line of print, guessing a word from the first 2 letters, and slow reading speed. Later, this converts into poor reading comprehension. So what happens potentially is, even if a student is able to read pretty fluently, they may, in the upper elementary, middle school, and high school, and even college, start experiencing more difficulties with reading comprehension of connected discourse. So the longer they have to read, the less they get. The symptoms that you'd be seeing or hearing about is the students need to read or reread the content areas, textbooks, more than once, and that can be quite discouraging. Writing, probably 40 to 50% of the students with ADD experience significant difficulties in written output. Their writing is often brief, slower and labored, maybe uneven, and certainly it would typically underestimate or underrepresent the depth and breadth of their knowledge, which is to say, if they were allowed to talk it out, the product and the depth of understanding would be substantially better. In math, some of the symptoms that we see with kids who are experiencing attention deficits are difficulty learning math facts, relying on fingers, or if you see tally marks on papers, slow computational speed. We'll see students forgetting to remember what they're doing in the middle of a multi-step math problem. Had one middle school student who was working on some multi-step math in my office, and he looks up at me and says, "Doug, where am I?" And I said, "Daniel, you're in my office." He goes, "No, I mean, where am I in this problem?" And the reality was 2 or 3 steps into it, he literally lost his way. And I said, "Daniel, does this happen often?" He said, "All the time, and I used to think, like when I was in 3rd grade, I was really good at math, and I don't know what's happening. Now in 8th grade, my grades are going down." Just want to make a comment about relationships. Some of the kids with ADD will miss cues, social cues, may present as less mature. Parents may feel like they're overprotecting or doing something wrong that's causing this. Not necessarily so. They may be easily bored with friendships and move on. And this also takes a huge toll on families. Homework time can be a very high stress environment. The normal kind of pulling back that parents would love to do to let the student or their child proceed on their own independently, they're not able to do it. And as it says in the right column, parents' confusion about can't versus won't, and quite frankly, parents get as discouraged along the way as do the kids. So if you're looking for a list of symptoms or impact of these symptoms, check out document number 2. The center section, the behavioral symptoms we've already talked about in terms of distractibility, daydreaming, appearing unmotivated, easily bored. The key thing here is that what appears to be one thing could actually be something else. And that isn't to say that ADD is the cause of all these symptoms. It could be a host of other things, but that's why comprehensive evaluations are part of what we do. So I think hopefully this will stir up a few questions. Sometimes a picture is worth 1,000 words, and so we're often, Dr. Bulten and I are trying to craft metaphors or word pictures that would help students or their parents to understand it. And one of our staff here came up with this uphill soccer field, and I thought it was really poignant in the sense that if you're a kiddo with ADD, it can feel like you're playing uphill, and it's very frustrating because you could be working and playing twice as hard as the other students, and with
they're on a flat playing field.
Exactly. And it's discouraging for the coaches, and this example would be parents or teachers who are trying to coach them up. The other picture that's there is the quieter form of ADD. I just think of it's hidden, we call it sometimes hidden in plain sight. These kids would really like to do well and are working at it very hard, but people don't realize that below the surface, there's a hidden current pushing back on them all the time. So keep those in mind. And so we better talk a little bit about the cures. And I'll just start off so what do we do about ADHD? And we're going to talk about kind of non-medical first, but realizing that a lot of the non-medical structural strategies really work best in the context of appropriate medication if the student meets diagnostic criteria. So creating a prosthetic or structured environment, we're just going to tap on a few things. One, externalizing instruction. Had parents in a couple weeks ago, and their son, in this case, has excellent hearing, but I counseled them to pretend he cannot hear, pretend he has no ears, and as a result, the more we talk, the less he gets. So externalizing instruction includes creating lists, listing every step with check marks and pictures to support them in that regard. Externalizing time, Dr. Bulten talked about many of the students with ADD are time blind. Remember, I think it was a comic where Dennis the Menace was talking to Mr. Wilson and says, "Hey, Mr. Wilson, isn't it always now?" So Dennis didn't look much ahead or much backwards. He lived richly in the moment, but they are time blind. They often lose track of time. We sell a tool called the time timer. Parents can use egg timers or whatever to externalize time. Another area, and I'll kind of go through these quickly because we want to save time for some questions, but externalizing working memory. Difficulties with working memory, which is kind of the mental counterspace of the mind, is a huge issue with students with problems with attention deficit or executive function breakdowns. They seemingly have a very limited mental counterspace, and the more information that gets put on it, the more falls off the other side. So we have to externalize that in terms of providing visual support, much like externalizing instructions. Externalizing motivation is just providing lots of feedback, frequent reinforcement, and actually tighter accountability. And the reality is that behavioral therapies are best done at the point of performance. If they need to be reinforced almost immediately, which is actually quite a bit to ask when you think of teacher requirements. Lastly, externalizing multi-step tasks. So, for example, if a student is really having struggles with the multiple steps of writing, multiple steps of long division, we actually write out each step in a cookbook fashion whereby that student can re-reference, go back to those steps and find out what step he may have missed or stay on the trail because the steps are kind of laid out in a very precise, specific, step-by-step fashion. So I guess we're doing okay with time, right, Katie? Okay. We're okay. All right. So I'm going to pass it over to Dr. B. We can, Dr. Bulten, we can talk more about any of these issues once we get done with this and field some questions, I hope.
Yeah. Okay. I oftentimes, as I'm evaluating a patient, I go over everything that Doug has just gone over, but then I say, you know, to do that alone is going to be very difficult and not very productive. And the kind of the oil that makes these previous steps work is the medication. And there are, I'm going to expand on this slide just a little bit. First of all, there are non-stimulants and there are stimulant medications. The non-stimulants are primarily Strattera and Intuitive. And we use those as adjuncts, add-ons to cover some areas, but they're not nearly as forceful as the stimulant medications. Just a word about stimulants in general. There's a lot of bad press. If you listen to people like Tom Cruise or something like that on the Today Show, you get scared away from it. I oftentimes say if anybody needs medication, it's Tom Cruise. But anyway,
we'll leave that aside, right?
The good news is that stimulants have been around for a long, long time.
How long?
Since 1937, as a matter of fact. The first one was Benzedrine, and Benzedrine was used by a doctor out on the West Coast for hyperactive kids. And Ritalin and its family have been in use since 1955. The amphetamines, Adderall XR, and Vyvanse have been in use since, before 1994, but that's when they started to be used for ADD. Anyway, and they are abundantly safe. People do not die from stimulants. I've had kids who've, in a fit of rage with their parents, have taken an overdose, swallowed their whole bottle of pills. They wish they could die, but they don't. They may end up in the ER for a while. They have their blood pressure monitored, but their heart may pound like crazy, but they are very, very safe, especially if they're taken as they're prescribed, not to take the whole bottle. There are two primary families of stimulant medication. There's the methylphenidate family, and that the original one in that one was just plain old Ritalin, and a few people still use plain old Ritalin. I don't certainly no kids on Ritalin because it's very short-acting. It lasts about 3.5 hours, so that means you've got to take it about every 3 hours so that you have a smooth course throughout the day. And prior to the long-acting medications that are listed here, that's all we had was the short-acting Ritalin, and these kids were trucking down to the office twice a day to take their medicine, and that was quite a stigma. So the primary methylphenidate medication that I use is Concerta. Most doctors tend to lob onto one that they kind of like, and then they stick with that in a family. I like Concerta because it's generally smoother and longer lasting than any of the others. Ritalin LA lasts maybe 6 or 8 hours. Ritalin SR is based in a wax matrix and is very inconsistent. Daytrana had some hopes that have proved rather futile. It's a patch that's worn under the underpants, and it just never took off. Focalan XR is a variant on methylphenidate. It's a dexmethylphenidate. It does not last quite as long. It's, again, about a 6 or 8 hour one. So to get a kid through his school day and through the rest of homework time, you almost have to give some of these medications twice a day. In the amphetamine family, there are three primary ones. Immediate release Adderall came out in 1994. Adderall XR came out in 2001. And about 7 years ago, Vyvanse came out. And they're all essentially the same. They have different delivery systems, and so therefore one may be preferred over another. In my practice, I have about 600 active patients, and in my practice, about 75% of my patients are taking one of the amphetamine products, and about 25% are taking one of the methylphenidate products, mostly Concerta. So even just based on that, there's no way I can look at a patient and say, oh, you're going to respond to methylphenidate or you're going to respond to amphetamine. So just playing the odds, because I kind of like to have the first medication work, it makes me look better, I will usually pick something in the amphetamine family. Then I look at what kind of insurance they have, whether it's going to pay for a given medication or not. The Adderall immediate release and the Adderall XR are both generic, but there's a huge price differential in those. The immediate release is running between 75 cents and $1 per tablet, but you have to take that 2 or 3 or sometimes 4 times a day. The XR lasts 10 or 12 hours. That oftentimes runs, $4 to $8 a capsule. You can usually take that once a day. Vyvanse is the only name brand in the amphetamine family, and that is also rather pricey. But if people have insurance at all, the Vyvanse company has coupons that usually you don't pay more than $15 per prescription. If people are truly poor and they don't have any insurance and their income is of such a nature, and really the Vyvanse company is very, very generous on this, we can get the medication for them free, and probably, I'd say 30% of my patients taking Vyvanse are getting it free from the company because they qualify financially. In the methylphenidate family, Concerta is also generic, but it's also very expensive. It's kind of funny. These drugs go generic, but the price doesn't come down at all. It just recently came out that there are 3 manufacturers of Concerta, and only one is really, truly a Concerta generic, and that's the one made by the company Activus.
Right. Do you want to talk a little bit, Dr. B, about the importance of follow-up, adjusting the medicine, and, symptom reduction forms that you utilize in your practice?
As we talked during the first part, going through much of what we've talked about during this seminar, we're identifying which symptoms a given patient has that are providing a functional impairment, and that's worth mentioning that we only treat functional impairments. We're not treating symptoms. And so we've identified the functional impairments that we want improved. And then I always start out, no matter which medication I start with the lowest dose possible. And for kids, let's say for Adderall XR, I start out with probably 10 milligrams, and then I'll build it up every few days, every 2 to 4 days, keeping very close contact with them. I happen to use email a lot with my patients, and some doctors don't feel comfortable with that, but I find it to be very effective, and that way I can keep track of what they're doing. And we don't certainly have to keep them on a certain dose a month to see if it works. If you do that, the school year will be over before you find the right dose. So we build the dose up gradually and systematically. If I start with Vyvanse, I start with 10 milligrams for a day or two, and then up to 20 and up to 30 and max out at 70. And with Concerta, it goes by increments of 18 milligrams. So you start out with 18, and then after a few days, if 18 is doing nothing, then you go up to 36, and then up to 54, and then up to 72, and you keep going till you find the optimal dose. I do not believe that just improvement in symptoms is the end point. We want optimization of symptoms. In other words, we want the patient that's sitting in front of me to be indistinguishable in his behavior, in his academic functioning, in his socialization from all the other kids in the class. Now, that's not always accomplished, but that's our end goal.
One of the frustrating and potentially discouraging facts about students or adolescents or adults too, sometimes we call their profile a frustration profile, in the sense that if we look at their basic intellectual cognitive functioning in the areas of memory, language, higher order thinking, we would certainly predict that they should be experiencing quite a bit of success in whatever grade they're in. And yet, they often experience difficulty with production or output or execution. So how painful it would be to know what to do and simply be unable, not unwilling, to produce or demonstrate what you know. It was interesting, last night, it was 9 o'clock, a friend of mine was talking about, to me about his son, who is a freshman at a local university, and he is an individual who had no difficulties in school, high school whatsoever, very bright, and yet he is experiencing quite a bit of difficulty now at the university level. And we talked a bit about that the rate and complexity and volume of work has escalated significantly, and he or she may well have had attention difficulties that have been masked by a good spirit, strong intellect, supportive family, but now, being away from home, on their own, more demands for self-management, the symptoms of academic difficulty are bubbling up for the first time, and it's very alarming and discouraging to those parents. So maybe, what are you thinking, Katie? We need to transition to questions, or what are we doing next?
Oh, before we go into questions, I did want to go into some of the next steps. We do have quite a bit of questions here, and I want to make sure we have time for them. But just some next steps. As Doug mentioned, our offices are in Grand Rapids, Michigan, and we work with a lot of schools, as you can see on this map, throughout the U.S. and primarily in the Midwest. And Doug and his colleagues do a lot of comprehensive student evaluations with struggling students. And so, Doug, could you just talk briefly a little bit about those evaluations?
Well, yeah, I mean, the comprehensive nature of that is that we're looking to understand the student thoroughly, not just related to ADD, but from a neurodevelopmental perspective. I mentioned looking at their functioning not only in attention, but different aspects of memory, higher order cognition, language, processing speed, memory, along with a picture trying to get a profile of their psychological well-being. It's kind of what we do. So if you have a son or daughter that is struggling and any of this information is resonating, you could certainly check into our website and or shoot us an email. Be glad to talk with you. And Katie can talk a little bit about what we do in terms of partnering with schools.
Yeah, so we, as I said, we work with a little over 60 schools throughout the U.S., and those are those partnerships. We have a teacher consultant that will work with those schools to help schools include students with mild to significant disabilities. And those are all non-public Christian and Catholic schools. And so if that's something that you are interested in learning more about, I encourage you to visit our website or send us an email, and we would be happy to talk with you more about that. So those are just some next steps. And now we'll go to questions. I've got quite a bit of questions here. Someone wants to know, how do you acquire ADHD? Is it hereditary?
Yes, it is. It's the second most hereditable condition in the human genome, the first being height. And so as I'm evaluating a kid, I'm always watching the parents to see. I don't usually bring it up quite directly, but I'm always wondering, now, which parent did this kid get this from? And at one of our conferences, the speaker said, you know, if you're trying to treat a kid with ADD and you're not treating the parent with ADD, you're not treating the kid with ADD.
Another question is, how do you recommend bringing up this topic with parents of a student who is displaying many of the behaviors that, Doug referenced in the documents? You don't want to jump to testing or labels, but how do you start that conversation?
My recommendation would be have some of the documents that we provide you, or at least a couple of them, available to you when you talk with them, and just describe symptoms. And without making a, quote, diagnosis or even mentioning ADD or ADHD or anything of the sort, just demonstrate, provide a listing of the symptoms that you, I'm assuming this might be an educator who's talking here, see, and that, and to decide if these are symptoms that the parents are seeing as well. Bob, do you want to add to that?
Yeah, I'm really impressed by the fact that I've never, in my 40-some years of practicing medicine, seen a kindergartner go off to school with the attitude that I won't be able to do this. They all go saying that first day of kindergarten, yes, I'm going to conquer this. And someplace along the line there, that gets beaten down. And so this is not willfulness, this is not laziness, this is not that they don't care. They may appear as though they don't care, but it takes tremendous something to say, I can't do something. They'd rather appear as though they choose not to do it rather than that they can't. And so it's our job as the big people to, with tremendous empathy, approach a parent and say, your child really wants to do well, and it's our job now to work as a team to figure out why he isn't doing well.
What is the roadblock preventing him from using his gifts? I think it also is helpful to always start out with strengths that a teacher sees, and being empathic about the frustration that their son or daughter is experiencing in the context of knowing what to do and yet not able to demonstrate it in the context of their peer group being able to. Some of the biggest D words, we have all these D words, ADD, LD, and whatever, but the biggest word to watch out for is the D word called discouragement. And if that continues on and on, it becomes a big problem years down the road, where a student has experienced enough discouragement that they start pulling back and just giving up.
The other D word is dumb. I mean, I have adults coming in who have IQs in the significantly above average range, who have always considered themselves dumb.
Yep. Other questions?
Yes. Would you recommend that a parent shares with the school that their child has been diagnosed with ADD or ADHD?
We may differ on this.
Usually the school knows that something's going on. I mean, on every kid that I see, I get teacher input. I have questionnaires that the teachers fill out as well as the parents fill out, so the teacher knows something's going on. I don't always, I usually do encourage them to tell their teachers. in the adult range, it's a little different. You don't always go to your employer and say, I have ADD, because there's a lot of stigma that can be associated with that. But nowadays, with the long-acting medications, this should go no further than the teacher, because kids don't have to know that.
I think the teachers, if they're part of the team, and again, would be able to provide the medical doctor and parents feedback as to the efficiency or effectiveness of the medication, and not having that input, and possible, the rare case of their side effects at school, it would be very helpful if the teacher be on board. It's a trust issue. I think largely a trust issue. If there's that level of significant mistrust between the parent and the teacher, that's another whole issue. But 95% of the time, the teachers are on board, and I think can be very objective in their assessment of how things are going.
And that's different than it was 30 years ago.
Correct.
And somebody asked, to follow up with that question, if the child has ADHD, would they have an IEP?
Not necessarily. There would have to be some, again, if they have ADHD and it's controlled medically, they might be doing fine in terms of their skill development and their productivity. If they're in the public school, they would have to meet some other criteria. The ADHD falls in the public law under otherwise health impaired, which is part of the Individuals Disability Act that covers the country. So it's possible for them to have a IEP, but we work in many of the non-public faith-based schools, so that wouldn't be an issue for us. What do you think, Dr.
Yeah, very few of my patients have an IEP. On the other hand, as they're going into high school, they may be functioning perfectly well, but it's sometimes good to have it documented in the school records for ACT tests or that sort of thing, because they can get extra time then to take some of these.
The school psychs, the school psychologists here at CLC Network do a fair number of evaluations of middle schoolers and high schoolers, such that if they meet the diagnostic criteria and need extended time, that the documentation we provide may prove helpful to securing additional time on high-stakes testing as the ACT, but also as they transition into college. Note takers, different accommodations and strategies would be in place for them as they transition into the college level as well.
One person asked, how do you convince parents of the importance of medication for students with ADHD?
I'm glad I'm a teacher. I mean, I'm glad I'm not a teacher. I'm glad I'm a doctor, not a teacher, because
doctors give orders, right?
I oftentimes feel so sorry for a teacher who's struggling. They're doing everything they possibly can to accommodate this kid, and their best efforts just aren't getting real good results. And so hopefully through building a trusting relationship between a teacher and a parent, they'll be able to say, there are very safe medications that can help this. Now, if a parent is adamant they will not put their kid on medication, you can lead horses to water, but you can't make them drink.
Right. And sometimes it's a timing issue, and it's a journey for parents to come to acceptance. And I think we have to offer parents a lot of support and grace. Also documenting all the strategies that have been put in place. Most parents, honestly, want to do the best for their son or daughter, and with education and trust building, many will come to the conclusion in a trusting way that medication should be tried, again, if the symptoms are significant. I think using word pictures, metaphors, analogies, these documents, hopefully, that of a raised soccer field and the like, can lower defenses and help parents to really understand. It takes courage, quite frankly, for teachers to bring it up, and we in our offices hear the outcomes. Some parents are so thankful that the parents had the courage to bring up the issue.
Teacher, you mean? Yeah, the teacher had the courage to bring it up.
Some parents are so grateful, and others not so much. And so that's where I think it's also important to have administrative backup in situations like that to know what to say and how to say it.
There's one resource that I recommend to all my patients that I'll just mention. It's called attitude.org, ADDITUDE.org, and you can subscribe to it for not very much, $25, $30 a year. You get 4, I think, paper copies a year, but you get an email 2 or 3 times a week, and they cover all ages and all sorts of things, and they offer free webinars and so on. So education is a major part, and you can always offer that to parents if they're anti-medication.
I think last question. We had somebody that wrote in and said they have a student in their 5th grade homeroom who has ADD and will blurt out in class. And when they're asked to stop, they won't listen and they will ignore them. And it's becoming a problem at the school, so and it disrupts the learning process for other students. So just wondered what some of your thoughts or recommendations are for this teacher in addressing this behavior.
I'm assuming the kid is not on medication, and if he is on he or she is on medication, it's either the wrong medication or the wrong dose. The key to medication management is finding the right medication at the right dose. And a kid that's having overt ADD symptoms, is either not on medication or is on the wrong one or the wrong dose. I feel very sorry for that teacher. Again, I'm glad I'm not that teacher, because what can he or she do?
Well, I feel sorry for the student as well, because he or she is needing intervention. If the situation is the child has been diagnosed with ADHD and is not taking medication, then he or she and the whole team is going uphill, and we're relegated to a variety of non-medical structural things that we talked about before. And sometimes they just have to have timeouts away from the environment, de-stress times, have the teacher have closer proximity, break times away, and honestly documenting all the strategies that are being tried. And if they work, wonderful. If they don't work, I don't feel like teachers should feel responsible because basically we're asking them to treat a medical condition with educational and behavioral strategies. It would be like saying a person is having an insulin reaction and we're recommending a behavior modification program.
Yeah.
That would be silly and not particularly helpful, and yet teachers are put in the position of trying to address this as best they can, a medical problem, and that fact is so critical to this whole conversation, I think, in terms of furthering parents' knowledge. A lot of what Dr. B and I do is teaching and providing resources, and the handouts that you have from this webinar is just the tip of the iceberg of a lot of the materials that we have. So don't hesitate to shoot us an email if you want to follow up in any way.
Yes, so we have, we're out of time, but we thank you so much for attending, and thank you to Dr. Bulten and Doug Bouman for their time. And if we didn't get to your questions, we will respond to you in an email as best we can. And if you have any more questions, certainly Doug's email is on the screen, and we invite you to connect with CLC Network on Facebook, our blog, or Twitter, and stay in touch. So thanks for being here today, gentlemen, and thanks for attending. Have a good night.
Good night.
Good night.